The UHC Delivery Lab was actually born out of something called the AHI Commission. And every 2 years, AMREF holds a conference called the Africa Health Agenda International Conference. And in 2021, a commission was set up to create a report on the state of UHC in Africa. And what we did is we translated that into making sure that this isn't a report that sat on shelves and wasn't utilized for the Africa region. We wanted to set up the UHC Delivery Lab as a home for these recommendations to be actioned by state and non-state actors.
So when we designed the UHC Delivery Lab, it came out of the desire to actually find a way towards universal health coverage that is country-led and that is actually context-specific.
So the UHC Lab is different from other initiatives in that it's very specific. The interventions and the projects and the work that we do is very specific to each country's context.
What the report showed us back in 2021, it showed us that still more than 500 million people on the African continent were still not accessing, care as they should.
For us as an organization that is locally based in Africa, grown out of Africa, and that actually is located in Africa, we have an interest to ensure that every government finds its own pathway, not externally advised, internally discovered towards a common goal of ensuring that everybody everywhere within the country has access to the services they need, when they need them, where they need them, without financial difficulty, within the available fiscal space.
When we looked at the landscape, what some of the priorities that actually emerged from the AHI Commission report was primary health care, people-centeredness, focusing on communities, prioritizing health systems that actually respond to people's needs, rather than health systems that just treat diseases.
We knew that there is a desire and a political will to achieve universal health coverage in many countries in Africa.
We thought it was more useful for countries who have gone a little bit of a step further to learn from each other, because it's those small steps that actually make a larger difference. Because we always look at those kind of big strides, but those are things that were actually done over time.
We are pairing countries that are almost at par in terms of the economy, in terms of the culture, in terms of the health systems. So it's very important to learn from your peer as opposed to somebody who is way above where you are.
So we started off with Kenya because one, AMREF is headquartered in Kenya. And in terms of ease of implementation, and being able to explore a lot of things based off of the knowledge we have, because we've been in Kenya for more than 60 years, right?
The reasons why we proposed Ethiopia to include in this endeavor is one is the implementation of the primary health care in Ethiopia is relatively strong, and there is a good political commitment from the government as well as a PHC. And if you see also the strategic documents of the Ministry of Health, including the previous health sector transformation plan and also the current health sector development and investment plan, the goal is to achieve universal health coverage through primary health care.
And Senegal really was a no-brainer because we wanted to focus on making sure that we had a francophone country as well included in this.
In Senegal, as we have a younger population, because the 50% of the population are young, and also we are facing to some issues according to youth employment as well as population employment. And right now with this project, we are trying to improve all of these aspects, to move towards UHC.
So phase one was the Ethiopian people visiting the Kenyan people, and then phase two was now the opposite of Kenya visiting Ethiopia.
I think Ethiopia has a very good model on how they train their community health extension workers. So that also was a very good learning that Kenya has tried to embrace. And then also the Women Development Army in Ethiopia working very well, which is almost our equivalent of the CHPs in Kenya.
And we had a workshop where colleagues from Kenya Ministry of Health presented their experience in terms of the development, implementation, and also challenges of the primary care strategy framework. And we even facilitated a field visit to Kisumu County, where they had the opportunity to learn the actual implementation of the primary care strategic framework, but other primary care and community health initiatives in the ground. So that was very helpful.
So Kisumu County have actually done a lot of work within the primary care network system to bring down their maternal mortality rate, which is one of the ways that a lot of systems measure success in the primary healthcare space.
At least we took 3 major lessons when it comes to primary health care and universal health coverage. One was in terms of legislation that Kenya is making when it comes to primary health care, including the Universal Health Coverage Act, the Primary Health Care Act, and some of the legislative initiatives when it comes to payment of community health workers.
The experience about the country pairing was a bit big of a challenge, given the timelines that we had in accomplishing the activity. But given the team the team with other countries and the coordination that we had with the other administrative associates in other countries, it was great.
Generally, in Kenya, insurance coverage was very, very low, to a level of less than 30%. And that affects access to health services by communities. It also affects equity, representations of all populations.
The UHC index in each country is vary, and we take Ethiopia is near to 53. So for the planning of 2030, with the world are planning to achieve UHC. So we need to improve this number from 53 at least to near to 90 and above.
When we say that we have learned how they're doing their insurance system, the community-based insurance, health insurance system, and do the same in Kenya, from there I can say that increasing our insurance from the current around 1921 to over 90% will mean people are able to benefit more because they'll not have to pay out of pocket anymore.
And of course, it's to make sure that people have financial protection. And sometimes we forget what financial protection really means. It's really making sure that people don't have to make the decision between putting food on the table or taking someone to the hospital.
The big take-home points I would say that I've learned from UHC has been working in policy, working at the grassroots level with communities, and seeing what implementation processes look like.
As we were presenting on social participation in Geneva, these global resolutions, they actually matter because it's countries who are responsible for implementing them.
The main thing, the biggest of it all, is bringing the community member to the policy-making tables, having their voice held, be it through collection of information in the surveys that we've had, in the focus group discussions we've had. We've really had the voices of the communities.
So having community health workers sitting on the panel to be able to talk about what it meant for them to be involved in delivering care and what these reforms actually mean for them in their service delivery, what that means. For me, that's the impact that you translate, that I can speak to right now after the 3 years.
The lab has been able to ensure that ministers are able to convene together. Ministers are able to have discussions on different issues that matter as they discharge their mandates, and particularly surfacing issues that touch on primary health care, issues that touch on global health security, and how these issues interface with progress towards UHC.
The impacts are strategic and they're long-lasting. Though we've just been able to scratch the surface, there's still a lot.
It's those little steps that really translate into long-lasting change. And working with policymakers, even if we are able to change one policy, it's actually a really huge feat.
One of the key things that has come out as very unique for this particular project is that it focuses more on learning, knowledge management, and also innovation.
Yeah, quite a number of communication products have been developed, including posters, just explaining on, just breaking down the whole aspect of social health insurance so that for people to understand, and also in different languages and even a mixture. Sometimes, for young people, there is a language they speak, so just bringing that out.
We have implemented community-based health insurance in all regions and city administrations. Currently, we are a federal state, so we have around 12 regional states and also 2 city administrations.
We just catalyze, or we just use in order to catalyze change at community level and be sure that we are in alignment with our strategy of community engagement was a woman group association. Because in Senegal, for each locality, you have this kind of woman group, and they weekly meet, bringing contributions in order to help in case, or if needed, the population to carry out some issues.
I'm happy that we are living communities, much as it's work in progress, but we're living communities more empowered with information and also more motivated to enroll to health insurance and also to make active changes when it comes to the health.
We want to make sure that those elements of feedback and community prioritization, community engagement, those are what are highlighted.
We say the human being, the greatest asset someone can have is the human capital. And therefore, to us, that has been a very good model that has worked quite well for us.
First of all, when you look for partnerships, when you're out there saying, who are those people or organizations that are aligned with the work that we're doing? Typically, you'll find them in the spaces that you're operating. And we look at not just what can the partner deliver, but what can we deliver together to accomplish a certain goal. In this case, we were looking at universal health coverage.
So the support coming from implementing partners really complements what we are implementing. So I would like to thank all the efforts made by our partners to support and also improve overall the health delivery system of Ethiopia.
In conclusion, I would like to thank School Foundation and also AMREF HQ for giving this opportunity to us. Even with the limited resource, we try to showcase how we can support the Ministry of Health. We can bring relevant stakeholders within the health sector and outside the health sector and support the implementation of UHC and also support critical areas of the Ministry of Health and the Ethiopia Health Insurance Agency.
Personally, from the success we have seen in the current project, I'll recommend that UHC Lab expands its scope. And why I'm saying that is we have seen a lot of successes, and what has happened in Kenya, the learning between Kenya and Ethiopia, has been a lot of good practices, and a lot of African countries are trying to do the same thing. So talk of Rwanda, Uganda, South Africa, they're all trying to achieve UHC through PHC.
So it's now to dig our heels deeper into what the key things are that we found in the 3 countries and really extend and stretch ourselves into a much more deeper technical engagement.
For the next steps, what we want to achieve with the UHC agency is to strengthen the quality of care. Also work on the digitalization. It is very important to have a digital tool that will help to set the membership.
Learning, especially when it's country to country, it takes time. You know, you have to break the barriers within the political economy. So if, for example, it's a project that goes for 1 year or 2 years, you may not be able to achieve all that. So you are likely to leave things hanging. So maybe moving forward is one, having more unrestricted funding because it gives you the leeway to, you know, play around and engage in a strategic manner, and then 2, having kind of long-term kind of funding also will make a lot of sense to the project.
So we have worked with SCORE and we've accounted for every coin, but it's been flexible and restricted, meaning it's been, rather than compliance finance driven, it's been objective driven. That's the difference between unrestricted money and restricted money. Unrestricted money is objective driven, and the pathway to that place is then found as you go along, as opposed to restricted money that says, I want you to do X number of meetings, meet Y number of people, and then that means that if there was a change that you need to make, then you can't make it.
we want to bring more people to be able to co-create with us, to work with us, to develop these knowledge pieces with, so that it's really reflecting a more continental view. So it's not just, just us in AMREF.
We would be hoping to have Skoll Foundation continue working with us on this journey, continue supporting this peer-to-peer learning platform that has Ministers of Health, and then of course provide continued support that would lead to more evidence generation and scaling of the different impacts that we've already had with the Africa Health Leaders Policy Forum.
For that, we are going to be flexible country by country. We appreciate the support of Skoll Foundation, and we call upon other partners who we are working with to also find this pathway that is actually going to be locally discovered as the best investment for countries towards achieving universal health coverage.